right, I think I'll get underway if you don't mind, folks. Thank you so much for coming on this rainy Saturday afternoon. My name is Brandon Marshall. I'm an associate professor of epidemiology here at the Brown University School of Public Health. I've been working in overdose for over a decade now. I moved to Rhode Island in 2012 and have been involved in many of the statewide responses to the opioid overdose crisis. And I'll be going through the state of the epidemic nationally and then focusing on Rhode Island and discussing some of our strategic responses to one of the top health crises that we deal with in the United States today. My talk will last about 40 minutes or so, and then I'm happy to take lots of questions, and we should all be out of here by noon. So what I'll be doing today is go through the state of the overdose epidemic in the US and then drilling down here in Rhode Island to look to see what this epidemic looks like in our state, and then go through the strategic response that we've been developing with our partners at the Department of Health and other state agencies through an academic collaboration with Brown. And then I'll finish by talking about some work that I've been leading, developing a dashboard or publicly accessible website that helps us track our efforts to address the overdose epidemic in Rhode Island. So let's get started with the state of the epidemic. I'm sure you've heard many things in the media about overdose, but I'll take you through some of the highlights now. This is what overdose looks like in the United States from 1980 to 2016. You can see essentially we have an accelerating, unabated epidemic right now in this country. These numbers are preliminary from the CDC, but we believe that upwards of 60,000 people have died of a drug overdose in 2016. And just to put that in context, this is the peak number of gun deaths that were observed in 1993, and we saw just over 43,000 deaths due to HIV and AIDS at the peak of that epidemic in 1995. So we are now dealing with a crisis that is larger in some ways than HIV/AIDS was at its peak. So for many of my students that I teach here, I believe that this will be one of the main epidemics that the young generation has to tackle over the coming decade. This is what drug overdose rates look like throughout the country. So this is an epidemic that affects all communities, rural, urban, red states, blue states. All of us in some way now are affected by the overdose epidemic in this country. Some of the hotspots of the epidemic you can see are in the Southwest, New Mexico, parts of Arizona and Nevada, and also high rates of overdose in Appalachia, parts of the Rust Belt, and then, of course, here in New England and Rhode Island. These are drug overdose rates in 2015 from the CDC. You can see here the top 6 states, of which Rhode Island is 5th highest in the nation. So we have been dealing for a long time with overdose, and as the epidemic continues to accelerate, we remain among the most highly affected states in the nation. And the national average is shown down there. So these are what the numbers look like in Rhode Island. We've had a doubling of drug overdose in the last 5 years in the state. Last year, there were 336 drug overdose deaths across the state, affecting pretty much every town and city. The numbers in 2017 are preliminary. This represents data through about August of 2017. So we're still waiting for some of those cases to be examined, and of course we'll be watching over the coming months to see what 2017 does end up looking like. But based on our projections, it suggests that we at least now may start to see a leveling of this epidemic in Rhode Island, at least perhaps somewhat slightly lower than the peak in 2016. Hopefully due to a lot of the great work that's been going on, which I'll talk about a little bit later. So you may have heard about opioids, so I'd like to just talk about opioids a little bit. In Rhode Island, about 82% of those drug overdose deaths that I just showed you are due to a class of drugs known as opioids. So these are substances that are used in medical settings across the country and around the world. They are basically any drug that attaches to a receptor in the brain called the opioid receptor. And when this drug attaches to that receptor, it causes pleasurable effects and euphoria and also very effective pain relief, even in severe injury. And that's why it's used these drugs are used so often in medicine. The whole class of drugs can include a bunch of things. We have drugs that you might receive during a dental procedure or acute pain or during surgery, to illicit substances such as heroin. All of these are within the class of opioids. And these drugs are actually quite similar to each other. This is the chemical structure of morphine that you might receive in the hospital, and this is the chemical structure of heroin that you would buy on the street in Providence. The formal name of heroin is diacetylmorphine, so it's actually the same as morphine, just with two acetyl groups, one here and one there, but otherwise the substance is very similar. And when we look at the effects of opioids, taken in high doses results in a dramatically increased risk of overdose. And an opioid overdose in particular can be identified by what we call an opioid overdose triad of symptoms. So when people take opioids in high doses, the drug will start to cause respiratory depression and breathing slowly, unconsciousness or someone who can't be woken up, and then also another symptom would be turning blue or also having pinpoint pupils. So those are the classic signs of an opioid overdose. An overdose can actually happen over the course of hours. The respiratory depression can be quite slow and eventually can lead to starving the brain of oxygen and then subsequently death. So because that takes a while, we do have the ability to intervene. If you do witness an overdose, you can call 911, and there are effective antidotes to opioid overdose called naloxone, which can revive people and can reverse many of these symptoms. So I wanted to just go through now what got us in this terrible mess in the first place. How did we get to where we are with this epidemic? In our country, we have dramatically and continual high rates of opioid prescribing in our clinical settings. This figure is from the New York Times in a paper published earlier this year, and it shows you that we prescribe enough opioids in our country to have every single person receive 17 days worth of supply. And this is actually down from a peak in 2010. And by far, we are higher than any other country in the world in terms of our utilization of opioids in clinical settings, second to Canada here by quite a bit. And this has been going up for a long time now. This is a figure from a review published in 2015, and it shows you very convincingly both the increase in opioid sales in clinical settings, shown in green, that have tripled since 1999, and the almost perfect correlation to that with increases in opioid overdose deaths, shown in red. And the blue line shows you the rate of admissions for addiction treatment due to opioids, which has also been increasing dramatically. So as these drugs continue to be prescribed to more and more people and in greater doses, we saw the outcome of that approach, which was dramatically increasing overdose death. And in addition to overdose due to prescription medications that you might be prescribed and taken in too high of a dose, when you have so many prescription opioids circulating in the population, that increases the risk for other people to use them non-medically. So what do I mean by non-medically? Non-medically would be using prescription opioids that were not prescribed to you, or using your prescription in a way that a doctor would not recommend, like using higher doses, doubling the dose, crushing or snorting these medications, or through other modes. This is a nationally representative study of young people called the National Survey on Drug Use and Health that asks children and young adults across the nation, if you're using prescription opioids non-medically in this manner, where did you obtain these pills from? And the majority of young adults who are using prescription opioids non-medically obtained them from a friend or family member for free. So with so many prescription opioids around and in medicine cabinets across the country, that increases the risk for young people to use them and start diverting them. A relatively small number of people actually buy these drugs from drug dealers on the street. Most are diverted from family and friends, and then some are obtained from a doctor and then used in a non-prescribed way. Now, what we've seen since around 2011 is increasing rates of heroin use and subsequent heroin-related overdose deaths. And I've been involved in some work that has tried to map some of these transitions in the United States. This was a study I did with some colleagues at Columbia and in University of California, where we used data from that same survey called the National Survey on Drug Use and Health that asks young people across the nation the types of drugs they use and when they started using them. And we looked specifically at heroin use in this sample of nationally representative young people. And among just over the 200,000 people that were surveyed in 2004 to 2011, just over 1,000 young people reported heroin use. 3 in 4, 76%, reported using prescription opioids prior to their initiation of heroin. So that provides strong evidence that yes, in fact, we do see this transition from starting with prescription opioids, perhaps using them non-medically, and that dramatically increased the risk of subsequent transition to heroin use. Youth in this study that reported non-medical use of prescription opioids had a 13 times greater risk of subsequent heroin initiation in this sample. And that, in turn, has resulted in increased heroin use in the United States. Again, data from the same sample, the NSDUH sample, that shows how heroin use has increased really across the country, but particularly in areas such as New England. Year over year, continued increases both in past year heroin use and also past month heroin use as well, as people continue to transition from prescription opioids into heroin use. And then to complete the picture, we now are dealing with a fentanyl epidemic in Rhode Island and across the country. So fentanyl is also an opioid, but about 50 times more potent and toxic than morphine, which is usually used in clinical settings. This figure is from the New Hampshire DEA, which shows very graphically, I think, the lethal dose of heroin, about 30 milligrams, and the lethal dose of fentanyl, about 3. So we're starting to see now fentanyl broadly seep into the illicit drug supply across this country. It has contaminated the heroin supply, and we're increasingly seeing it in seizures of cocaine and prescription medications that are illegally manufactured. So a lot of people ask me, why would you do this? Why is fentanyl coming into the drug supply in the United States? Why would dealers be selling it? So I'll show you a couple of studies a little bit later where we've started to look at this. But essentially, the reason why fentanyl is in our drug supply is because of profit. It is very easy to manufacture. It's a synthetic opioid, so you can just make it in labs. And about $6,000 worth of raw product brought usually from China can be sold for $1.6 million on the street, compared to much smaller profits when you're trying to traffic and deal heroin. The other thing, too, when you look at fentanyl, you need so little of it, it's much easier to traffic across borders. You can actually traffic fentanyl in standard letter mail, just in little baggies. So it's much easier to move fentanyl across borders from Mexico, from China, and other places, and that's largely why we see it so commonly now in drugs, including heroin. This is a figure from the Economist, which shows this pattern really nicely. So these are the monthly number of drug overdose deaths in the United States overall. And you can see from 2000s, when we had that uptick in prescription opioid utilization, concurrent increases in prescription opioid overdose. That has been increasing slowly over time. That uptick in heroin overdose started to happen really around 2011 for reasons that are not entirely understood. And that has been picking up ever since. And then several years later, the introduction of fentanyl into the illicit drug supply and that huge spike in fentanyl overdoses, which we're now dealing with. And I'm starting to think that the slope of that line is related in some way to how potent these drugs are. Prescription opioids, quite potent, and have been slowly increasing deaths. Heroin, more severe. Fentanyl, incredibly toxic. And once it's introduced, broadly spikes the overdose mortality that we see across the US. So turning now to Rhode Island, this is what the data looks like here in our state. So these are numbers from that earlier graph that I showed, the number of drug overdose deaths in Rhode Island year over year since 2009. I'm showing you here the number in yellow that are due to fentanyl. Over half of the drug overdose deaths in Rhode Island are now attributable to fentanyl. This is what our epidemic would look like if fentanyl had not been present. We would actually be doing quite well and would be seeing reductions in drug overdose mortality since 2013. But again, with fentanyl, it's completely changing the game and completely exacerbating the problem that we've been dealing with since the early 2000s. So I've been involved in some work that has tried to understand the phenomenon of fentanyl in Rhode Island and looking at the characteristics of people who unfortunately die from fentanyl overdose death in our state. This was a study I published with some colleagues here at Brown and with folks at the Department of Health, including Director Alexander Scott, through our academic collaboration. My team here at Brown is an amazing group of staff and students, has the unfortunate task of reviewing every single drug overdose case manually, and we extract information with the medical examiner's assistant on the characteristics of these overdose decedents. And what we found in this study was that 1 in 4 fentanyl overdose deaths were among people under 29 years of age. This epidemic has rapidly shifted into young people. And that is because since fentanyl is so much more toxic, the risk of death for any given use event is much higher than if you had been using other substances. And that results in death much earlier in someone's typical drug-using career. So we really have to start to think towards preventing use and scaling up our treatment in young people to start to get a handle on this problem. Also, 50% of these deaths had evidence of injection drug use. So as people have transitioned to these more potent substances, we've also seen rapid increases in the initiation of injection drug use compared to taking these medications orally or snorting or smoking these drugs. And injection drug use also increases the risk of overdose death because the drug you get is just much faster and much sooner into the blood supply, and that goes right to the brain and can cause overdose much faster. So this is another issue we're dealing with, is increases in injection drug use here and across New England. We've also collected very detailed data on where these overdoses actually occur. We collect the exact address where fatal overdoses occur in Rhode Island. So we can understand, and we're working now on understanding hotspots in the state where we typically see drug overdoses. And this was some early work from that research. So this is what's called a hotspot analysis. So you use geospatial analyses to understand where drug overdoses are clustering in Rhode Island. And what we wanted to do was see if the clustering of the non-fentanyl overdoses differed in some way from the clustering of the fentanyl hotspots. I thought that they would differ quite a bit. I thought that the fentanyl overdoses would cluster in urban areas or more impoverished areas, say in Pawtucket, Central Falls, Providence, and Woonsocket. What surprised us is that the geospatial patterning of the hotspots is very similar, pretty much overlapping, perhaps with some differences in some of the suburban areas. So what that indicates to us is that it's not one trafficker or one supplier that's promoting fentanyl. It really is contaminating the drug supply broadly and seems to be affecting people in the same way that all overdoses do across the state, with particular overdoses, hotspots, I should say, in Providence and Woonsocket and the north of Rhode Island. We wanted to start to understand and grapple with, again, this issue of why. Why is so much fentanyl in the drug supply, and why are people using fentanyl? This was a study that was led by our postdoctoral associate, Jennifer Carroll, who's now working at the CDC in Atlanta. She interviewed 47 heroin users in Rhode Island and asked them about their perceptions of fentanyl. Are you worried about fentanyl? Why are you using fentanyl? And what things do you do to avoid or reduce your risk of a fentanyl overdose? And these were the main findings from this study, sort of summarized down into bullet points. The first was that we saw overwhelming negative perceptions of fentanyl. You might have heard in the media this perception that because fentanyl is so strong, people are seeking it. They want that potent high. And what we found is very much that not being the case. People know that this is a very deadly drug, and the rapid onset is so fast that people don't even experience the euphoria of a high. They basically go right to passing out immediately, which is why fentanyl is used in surgery, because you can basically, of its strong anesthetic properties. So overwhelming negative perceptions of the drug. And an understanding that fentanyl is causing overdose death among people who use drugs across the state. There was some mixed messaging around how drug dealers either increase the risk or try to mitigate the risk to people that they are selling these drugs to. Some people we talked to said that their dealer tries to protect them from fentanyl. They warn them when they think there might be fentanyl in the drug they're selling, increase them to use less or use with someone else who can intervene in the case of an overdose. Other people told us that their dealers just sell whatever they have, and that there's really no concern for their health or safety. So we're doing more research now to understand how we could potentially intervene with dealers and try to identify best ways to reduce risk at that level. And finally, we found this phenomenon where people, particularly people who had overdosed on fentanyl, that is often a moment that prompts seeking of addiction treatment. And the problem, as you'll see later, is that trying to, even if you want treatment, that can be very difficult to access for many reasons. And there are many barriers which we're trying to overcome now as we scale up addiction treatment across Rhode Island. But fentanyl overdose often prompts a desire to seek addiction treatment in this sample. This is some other work that I'm just starting to do now with some students here at Brown. Undergraduates are helping me with this. This is a study that's funded by a seed grant from the Office of Vice President of Research here at Brown. There are strips that you can use, they look like this, kind of like pregnancy tests, to identify fentanyl. The test was designed for forensic testing in urine. So the idea is that you could detect fentanyl in the workplace environment, for example, in people who have to do urine testing. In Canada, with some of my colleagues in Vancouver, they figured out that fentanyl actually dissolves in water. So what you can do is put a little bit of your heroin in water and then use these strips to actually identify whether fentanyl is in that supply of drug. So we are the first study, as far as I know, in the nation to be actually testing with people who are using heroin whether they would like to use these strips, whether they'll test, how often they'll test positive for fentanyl, and if a positive test comes up, what kinds of things will they do to try to reduce their risk. Ideally, these folks would get rid of their drugs entirely. For people that are very dependent on opioids, we don't think that would happen. But if there's a positive test, people might use less than they normally would, or they might ask someone to watch them while they use drugs and call 911 if there's an overdose. So we're optimistic that this is one way that we could actually try to prevent fatal fentanyl overdoses in Rhode Island. So we've just completed the baseline enrollment of this study. We found 93 predominantly heroin users. These are young people, 18 to 35 years of age, which, as I mentioned, is where we're starting to see a lot of fentanyl overdose. Most people reported weekly or frequent heroin use, and about half had ever injected. We interviewed these folks at the Brown University School of Public Health. We then trained them how to use these fentanyl strips, give them about 12, and then are now asking them to come back to us and tell us whether they actually used the strips and how many positives there were and what they did if there was a positive test. We're just analyzing that follow-up data right now, but in terms of the baseline results, 1 in 3 had ever overdosed, so we're seeing a lot of overdose in this sample, and 93% wanted to know if there was fentanyl in their drugs before they used them. So this does suggest that people who are using fentanyl this may be a great intervention to reduce overdose risk. And again, at baseline, 95% planned to use the strips. And hopefully I can come back next year and let you know what the results of the follow-up are once we bring people back and ask them whether they in fact did use them. So I wanted to talk a little bit about our strategic response in Rhode Island to this crisis. I've been very fortunate to serve as an expert advisor to Governor Raimondo's overdose task force. And in 2014, this task force that she put together asked academics at Brown, including myself, Tracy Green, and Jody Rich, to design a strategic plan that would help to reduce overdose and address the opioid crisis across the state. The goal that the governor set forward was to reduce overdose fatality by 1/3 by 2018. And that has turned out to be a very ambitious goal and one that we are not reaching. So we need to do more and more and more, and we need more people looking at this problem. But nonetheless, that is the goal, to save lives and reduce overdose mortality across our state. I won't get into the details of the plan, but just as a 40,000-foot overview of what we're proposing here, we proposed 4 pillars, if you will. There's not one silver bullet to reduce overdose. We need a multi-pronged approach. And what we're focusing on is the following. Prevention. This refers to preventing high-risk prescribing. We're trying to reduce high doses of prescription opioids that are going out into the community, and also co-prescriptions with other drugs. Benzodiazepines are very risky when used with opioids, and Rhode Island has the 4th highest rate of benzodiazepine prescribing in the nation. So we put forward new regulations to try to encourage safer prescribing of opioids and also benzodiazepines and opioids. Rescue refers to expanding access to naloxone, that opioid antidote that I mentioned earlier. Community-based organizations, state agencies, addiction treatment centers, and the Department of Corrections are all distributing naloxone across the state. I'll talk a little bit about recovery later, so save that one for now. And I'll go through a little bit about what we're doing around expanding access to addiction treatment. The good news with this epidemic is that we have very effective a treatment for what's called opioid use disorder, and we need to expand access to that so everyone who wants it can use it. So this is what we're doing, just very briefly with treatment. We've developed what we're calling a Centers of Excellence model for the treatment of opioid use disorder. This is a hub and spoke model here in Rhode Island. So the idea is to have specialized centers of care that would provide all of the medications, which you'll see, which are effective for treating opioid use disorder, and a lot of other specialized services that doctors and primary care providers could refer their patients to, help them get stabilized on addiction treatment, and then refer them back to those primary care providers. So we just are in the process of licensing and rolling out the Centers of Excellence model now. The other thing that we're doing is trying to expand access to buprenorphine in particular. This is used in addiction or opioid treatment. It's very effective. It comes as a sublingual tablet or other modes that you can take and can reduce cravings and can help people stay off opioids and heroin. The problem is that federal regulations restrict the number of physicians and which physicians can prescribe buprenorphine. You have to go through what's called a waivering process. It's like a 10-hour training from the DEA to be able to prescribe buprenorphine to your patients. And that's because this is a controlled substance, so it is restricted at the federal level. So what we've done is tried to increase the number of physicians in Rhode Island who are able to prescribe buprenorphine to their patients. We've done trainings with the health department, and we're the first, the Brown Medical School is the first medical school in the nation to mandate buprenorphine training for all of their trainees, trying to increase the pipeline of physicians who can treat addiction and in particular prescribe buprenorphine. So this is what treatment access looks like to date in Rhode Island. We actually track where these physicians are, where their practices are, and which ones are able to prescribe this drug, this medication. And you can see we're doing not too badly. This shows you the number of physicians in each town across Rhode Island. We are still seeing gaps in some rural areas of the state, but nonetheless, we have increased the total number of waivered physicians who can prescribe buprenorphine from about 200 in 2014 to 350 today. So it is getting better, and we are increasing the number of people on buprenorphine across the state. But nonetheless, there are access issues, and we need to do better. These are the stats, as you can see. The goal was to have 6,500 patients on buprenorphine by the end of 2018. So far this year, we've had 4,500 people across Rhode Island access buprenorphine treatment. So it is going up. I think we could do a lot better. We're starting to identify both patient and provider barriers to buprenorphine. Physicians feel uncomfortable bringing up opioid addiction in their practices. And they're uncomfortable, even among people who've done the training. Some physicians tell us they're uncomfortable starting this medication. So that's one purpose of the hub and spoke model I mentioned, is to help primary care doctors refer patients they might not feel comfortable treating to a more specialized center, get them on buprenorphine, and then send them back to community-based care. The final thing we're doing with regards to treatment is to expand access to medication-assisted therapy, that's buprenorphine and another opioid medication called methadone, in the Department of Corrections. We have one jail and prison system in Rhode Island, one campus in Cranston, where all inmates are cycled through. And we are the first state in the nation to be actually initiating inmates with opioid use disorder on these medications. The standard of care across much of the country is to force people who were previously on these medications and who were become incarcerated cold turkey, to force them off these medications once they become incarcerated, or undergo rapid tapers, basically forcing people on to withdrawal as they become incarcerated. We're doing the opposite. We're screening all inmates for opioid use disorder, and among those inmates who are indicated for these therapies, initiating them on treatment. And this is to try to get at this issue. So release from prison is a major risk factor for opioid overdose death. People who were using opioids before they're incarcerated go into jail or prison. They don't have access to opioids anymore. So not only do they undergo withdrawal, but their tolerance for these drugs also drops dramatically. If you don't have appropriate care and transitions to appropriate community care when people are released, people start using opioids again when they have low tolerance, and that dramatically increase the risk of opioid death. We've been able, working with the Department of Health and the Department of Corrections, to actually link our records of people who have died with records from the Department of Corrections. And this shows you the proportion of all of our overdose deaths who were released from the Adult Correctional Institute in Rhode Island a year prior to their drug overdose death. About 15 to 12% of all overdose deaths were among people who were released from the Rhode Island prison system a year prior to that fatality event. So the idea is that to try to scale up addiction treatment in the correctional setting, to try to keep that going when they're released and reduce overdose death once they're on the outside. We've been receiving national attention for this novel program. This was an article in Stat News written up on the Rhode Island model for providing opioid therapy to inmates. I think we're just received funding from the National Institutes of Health to evaluate this program, so we're starting that now. I think if we are successful, one of the key reasons why we'll be effective is that the provider of this opioid treatment in prison is the same community clinic that's going to be providing care to these folks on the outside, which is very novel. So we have basically the same doctors, same nurses who are providing the in-prison treatment, transition these people hopefully seamlessly to care in their community when they're released. And I'm hoping that that continuity of care will help to keep people on treatment and reduce overdose mortality when they're released. So I wanted to talk finally a little bit about recovery. In Rhode Island, we're expanding and really investing in what's called peer-based recovery. So the idea here is to actually train people who have experienced addiction to become expert peer recovery coaches. We are a national model for this program. We've received a lot of attention in the Washington Post, CNN, and PBS. I encourage you to watch this documentary, which just came out on October 6th, on our peer-based model here in Rhode Island. The idea is to take peer recovery coaches and deploy them anywhere that you might be encountering people who are at risk for overdose. We have peer recovery coaches working in the prison system. We have peer coaches working in the hospitals. People who come in for an overdose then are seen by one of these peers when they're sitting there waiting to be released. And these peer coaches talk to them about possible treatment that might be available, and if they're not willing to accept treatment, give them naloxone kits, which can be used to reverse an overdose if they do continue to use. And Jonathan Goyer here, my colleague and friend, is also director of a street outreach program who canvasses across Rhode Island and goes and works with homeless people and other vulnerable populations to try to connect them with treatment and provide naloxone. So these are some data on our recovery strategy to date. The goal here was, you can see, 3,000 people enrolled in our peer recovery programs by the end of 2018, and to have 168 trained peer recovery coaches working across the state by that year. We're doing pretty well. We continue to scale up. This year we've had 1,400 people interact with a peer recovery coach. and hopefully that will continue to increase, and we continue to train folks who have experienced addiction and who can work in this program. And we're again starting to evaluate some of the outcomes, and we've just put in a grant to do a randomized control trial in the ED setting to formally evaluate whether interacting with a peer is more effective than interacting with a nurse or healthcare worker in the ED-based setting in terms of reducing overdose once they're discharged and getting people into treatment. So I'll just spend the next 5 minutes or so talking a little bit about how we're communicating all of this progress. My team at Brown leads what we call the Dashboard Project. When we started that strategic plan, we wanted to commit to improved data sharing and transparency. We wanted everyone across the state to know exactly how we're doing, where we're making progress, and where we need to do better. So the idea was to develop a website and make that publicly available so people could look at all of the data we've been collecting and understand all of the different strategies that are being rolled out. So this was launched last year by Governor Raimondo. It's called PreventOverdoseRI.org. I encourage you to go and check it out after the talk. All of the data I presented today is under See the Data. So that is a drop down and provides a lot of opioid overdose surveillance information. When we started developing this website, we quickly heard from stakeholders and family members affected by overdose and people who have overdosed themselves that they really need more. They need not just the data, but also resources, information. Where can you go to get treatment in Rhode Island? Where can you go to get naloxone? What is an overdose? So we've expanded the scope of this project, and we provide a lot of resources and information for family and friends, professionals, and also people who need immediate help to try to access care. So I'll just take you through a couple of the resources that are on the sites, and I'm looking forward to your questions. I just wanted to highlight that the whole project really is a phenomenal collaboration between Brown and my team at the School of Public Health, the Department of Health, the Department of Behavioral Health, and also the Governor's Office as well, who provides high-level support for this initiative. And that kind of interdisciplinary and interagency collaboration allows us to access data and analyze information pretty much in real time to help track the overdose epidemic as it continues to evolve across our state. We just published an article in the American Journal of Public Health that describes the process we use to develop this dashboard. We've been working with the CDC and with the National Governors Association. We've conducted about 12 technical assistance calls with other states who are interested in this approach, trying to roll out this dashboard method to track overdose across different jurisdictions. Staten Island developed one very similar to ours, and there's others being developed in Ohio, India, and other places as well. In terms of what's on the site, some of my students at Brown and also at the Rhode Island School of Design have developed some nice infographics that can be shared on social media, on Facebook, and are handed out to people in street outreach programs on how to respond to an overdose and some of the key things we'd like people to do, including call 911. The faster you can get emergency responders to the scene, the better, particularly if it's a fentanyl overdose, and some other basic CPR strategies as well. And as I mentioned, we seek to provide data for people to know what does overdose look like in your town. So this is an interactive map that's on the website that shows you the number of overdose deaths over the past 3.5 years in every town across Rhode Island. And we've received a lot of good feedback about this. There's a lot of towns where you might not know that they are experiencing overdose death, particularly in a town like Bristol or Warren. We've had physicians tell us when they see these numbers, that prompts discussions in their practice that, yes, overdose is actually a problem in our community. And boy, I should start talking to opioids about, talking to the risks of prescription opioids to my patients and start screening for opioid use disorder. So I think the more information we provide at a local level really empowers people to make change and also to reduce the stigma that is present with this disease as well. So that is pretty much all I have. I just wanted to finish with some acknowledgements. My wonderful team of staff and students who really lead a lot of this work. Everything on the website is really due to the students and staff that analyze the data. And my colleagues at the Rhode Island Department of Health, including the director who I work with very much on this project, and people at the medical examiner's office as well, who have been tremendous at helping us understand the patterns of overdose death in the state. and my colleagues, and also, of course, the funding. All of this is funded currently by the Center for Disease Control and Prevention. So with that, I wanted to finish, and I'm happy to answer questions, and again, just hope that you'll visit the site after this talk. Thank you so much. Yeah, I'm happy to answer questions. Yeah, in the back. Do you want to come up to the mic if you could so people can answer? Or I can repeat the question too.
Sure. Thank you, Professor Marshall. That was very informative. I have three related questions, please. First, do you have a sense of what percentage of opioid users, if they have a conversation with a physician or someone with one of the programs that you described, that would want to go down the path of either methadone or buprenorphine treatment, number one. Number two, how long does that treatment last? And number three, how often does the individual not go back to any sort of opioid or even other illicit drug use? Thank you.
Yeah, great. So we're just starting to analyze some of the data from the ED-based peer recovery coaching program now. And it is challenging. When people are revived after they've experienced an overdose and are brought to the ED, they are given naloxone, and that actually prompts withdrawal symptoms. So you feel terrible. And a lot of people just want to get out of the hospital and not interact with a recovery coach. So unfortunately, about 30% of people do refuse a recovery coach in the ED setting. The remainder do agree, about 70% do agree to at least remain in contact with a recovery coach. And they call them pretty much daily and then weekly after they've been discharged to try to keep connected with that person. The idea is that even if they don't want treatment immediately, the hope is that by staying engaged with a peer, at some point they'll decide to enter treatment. And we haven't actually looked yet to see at the uptake of treatment. It's a little bit too early, but we're going to be looking at that now. In terms of the duration of opioid therapy, methadone and buprenorphine, these are chronic medications. Methadone in particular is meant to be a long-term course of therapy. Buprenorphine can be a little bit different. The best outcomes are observed when people stay on buprenorphine for at least 3 to 6 months. It's not necessarily a lifelong course. Many people, after being able to manage their withdrawal symptoms and cravings, then can go off buprenorphine and lead very healthy and successful lives. And I've been able to meet many people, including Jonathan, who's in recovery himself, who are doing incredible work across the country. So these treatments are effective, and people can eventually stop taking the medications and be in lifelong recovery. Yeah. Sure, yeah, if you would. There's a fan up here, so I'm having trouble hearing as well.
My first question was, statistically, do you know what percentage of people who become addicted or are addicted are actually prescribed that drug versus people who are, getting it around the bend because they're seeking drug use? So, which lends myself to the second question of, are physicians welcoming educating their patients or thinking about prescription and prescribing differently?
Yeah. So in the 90s and in the 2000s, the majority of people who became dependent on opioids had received a prescription from their physician. So that was really what's called an iatrogenic phenomenon. People started to experience dependency due to opioids that they had been prescribed. Now, probably less than 15% of people we see with opioid use disorder started with a prescription. As we saw in that earlier data, many people divert prescription opioids from families and friends who have prescriptions, or especially among young people now, start right away with illicit substances. So they may be buying heroin or prescription medications sold by dealers on the street. So we've seen a rapid shift over the last, I would say, 7-8 years, where we now predominantly have an illicit drug epidemic in Rhode Island. 85% of the deaths are due to illicit drugs now, not prescriptions. And remind me the second question again?
It was, so it sort of speaks to, the pain, I guess, that first half of our physicians thinking about making different prescription choices. I have patients that I see whose doctors are assuring them that their opioids are not a problem, chronic use, and I didn't know how receptive physicians are to making changes?
Yeah. So we're taking a two-pronged approach in Rhode Island. We want to deal with people who are on chronic opioid therapy differently from people who are first starting these medications. In the chronic patients, the thinking is that if you were to taper or discontinue opioids too quickly, that could prompt someone trying to find opioids or heroin on the street. So we don't want to clamp down too quickly on the patients that are currently on chronic therapy. We might want to talk to them about perhaps tapering their dose over time, and that is happening. We are addressing the acute conditions more aggressively. So we now have launched statewide regulations that for patients initiating prescription opioids, the maximum number of doses they can receive is 20, I think, per prescription. And the idea is then to avoid having people for like a back injury end up on long-term opioids. The longer you take these drugs, the greater the risk of dependency. Lots of people receive morphine in the hospital for surgeries. You're receiving these powerful drugs, but you don't become addicted. You're only receiving them for 3 days maybe in hospital. The risks really build up if you're using them for a month, 2 months, and 3 months, and so on. And we are seeing progress. In Rhode Island, our total opioid prescribing numbers have been reduced by 16% since its peak in 2010, and that's actually the biggest decrease in the entire nation. So we are doing good work on that front, but you don't want to push too aggressively and too quickly and sort of avoid unintended consequences of pushing people into the illicit drug market. Yeah.
Off of that question, thank you for bringing that up because I have the same experience. You did show your graphs go up, and I would be interested in knowing the trends that were there prior to the 1990s because I think that's the time when a lot of studies were done about, physicians not paying enough attention to pain. And so number one is, what is your thought on pain as a fifth vital sign and its role in over-prescribing opioid medications? And another comment, I think, from a physician perspective, there are some medications that have a higher street value as far as opioids are concerned, but that information is not necessarily available to the physicians if you're not, really delving into the pain, treating pain constantly. So physicians who may not be exposed to this theory of, some opioids are more addictive than the others, and methadone is really not that hard to prescribe as a drug. That's just a comment that I think there is a dearth of, education even among the physicians who are coming out and prescribing these medications. That gap, we may need to address that.
Yes, that's an excellent point. So, these medications are essential. They're on the WHO list of essential medications. And in some countries, there's an issue with untreated pain. And we do have a significant number of Americans who are on or in pain as well that does need to be addressed. And in the 90s, there became increasing emphasis on treating that pain. And there was a push by pharmaceutical companies to promote these drugs as effective pain relief. And they are effective at acute pain relief, but what we're starting to see as longer-term studies are done is that they actually aren't that effective at treating long-term chronic pain-related conditions. The problem is we don't, as you probably know, have a lot of other effective pain relief. So there's a lot of research that needs to be done on perhaps new medications that are effective but have a lower addiction profile, and other alternative pain relief strategies, physiotherapy, exercise. There's a lot of good work going on that front as well. And you're right, I should say that the opioids do affect the receptors differently, and so some can be more addictive than others. So I don't know as much about that as others. I'm not a physician, but myself. But you're right, we could probably alter the drugs that are prescribed, and that would certainly be a positive direction to move in as well.
This was a very nice talk. My impression as a physician was that this opioid crisis was primarily because of excessive prescription of opioids by physicians and nationwide. But here I see a transition happening where now it's moving to illegal drugs, heroin, as well as fentanyl available on the street. That makes it more difficult. And what's the explanation of why this transition is happening to illegal drugs from this, what we thought was a prescription drug crisis? And is it a Rhode Island specific problem, or is it going nationwide?
We don't completely understand all of the pathways that lead someone from prescription opioids to seeking heroin. I think there's a lot of underlying vulnerabilities that we have to still examine. But we are seeing it across the country. We have seen this transition move very quickly and in a very widespread manner. My thought is that what happened is we increased the number of people who are exposed to opioids since the 90s. As more and more people are prescribed these medications, it creates a large number of people who are dependent on these drugs. And then once prescriptions stop or are tapered, or a physician wants to take someone off, people will search for other options. And the illicit drug market in this country is very sophisticated, and the cartels know what they're doing. And as soon as they saw a huge demand, they move in to fill them. And I think that's what we're seeing, is that basically supply of illegal drugs is just following the demand. And so you're right, it will be very challenging to address now that we have so many sort of intertwined epidemics moving at the same time. Both prescription opioids we need to address, but we also need to get a handle on illicit drug use as well. Yeah.
I'm a high school teacher, and we have drug prevention programs. And I've heard from a speaker addressing the teachers and the students that unlike other addictions, alcohol or smoking, that opiate addiction, you cannot fully recover. And so I'm wondering what your thoughts are that, and how do you define recovery?
I believe, and I've seen myself, that is untrue. I've seen people who, and I know people, many people, who are homeless and injecting heroin every day on the streets of Providence, and are now meeting with the governor to help address this crisis, and wear suits and travel around the country and talk about their recovery. So recovery, lifelong recovery, is possible. I strongly believe that, and I think the evidence shows that. And I think we need to do better at hearing and listening to stories of people that have experienced terrible suffering and addiction and now are leading very successful and healthy lives. So I think it's more similar to many of those other types of substances that you mentioned, in terms of treating them and then moving on to longer recovery. The cravings never truly go away, right? And the temptation to use never truly goes away. And that's the case with really any drug addiction. Recovering alcoholics will tell you that, and people that are smoking will tell you that. So, but I choose to define recovery as being able to lead a healthy, productive, successful life. And you can do that still with being able to manage those latent temptations and cravings. Yeah. Any other questions? One more? Yeah, sure. Great.
Thank you. What can you tell us about the demographics in Rhode Island and in, throughout the United States of individuals who use opioids, either the prescribed type or through illicit means? And next question is sort of open-ended, but if you had no constraints, we had no constraints on resources, money, people who could be involved, taking into account those demographics, if all our lives depended on it, on getting these lives saved, what would you do?
Yeah.
Thank you.
So in terms of demographics, starting with gender, men and women overall use opioids sort of fairly similarly. but men are actually much more likely to die from an overdose than women, for reasons not entirely understood. They might use more, particularly once they become heavily dependent. So about 3/4 of our drug overdose deaths are in men. There is a narrative that this is a white issue, a predominantly white issue. That is not true. This issue affects all race ethnicities. We actually have the second highest rate of drug overdose mortality among Hispanics in the nation, behind only New Mexico. So it may have started in the states where we first started to identify the epidemic, in West Virginia. That is an overwhelmingly white population, so that might have where we saw the narrative get started. But now we do see prescription opioids, heroin, fentanyl affecting all race ethnicities. In terms of what I would ideally do, I think we need at least to consider two strategies. The first is dramatically increased access to treatment. I didn't mention it, but only 10% of people who could benefit from opioid treatment actually have access to it. There are issues around just having enough doctors to be able to prescribe these medications. There are financial barriers, co-pays, insurance issues, and many other sort of structural problems. We force people to go through this convoluted and very confusing system to access addiction treatment. It is not as low threshold as it should be. So that's what I would do. We need, significantly more funding to scale up addiction treatment and make it more broadly available to people across the country. But there's a second part of that story, and that is that treatment, not everyone who is addicted to opioids wants treatment or is at a point where they can accept treatment. You need to have programs in place that keep people alive until that point that they can actually then consider entering into treatment. And that's where we look at harm reduction, which is where that fentanyl strip test idea comes in, is that it may keep people using, but it keeps people using long enough so that they don't die and that eventually we can get them into treatment. Another intervention that is in other countries are supervised consumption facilities. So these are places where people can use drugs under the supervision of nurses and doctors, and then they intervene in the event of an overdose and can also refer people to treatment. And it's very controversial. A lot of people have said to me, oh, well, that enables addiction, right? You're bringing people in and you're watching them inject drugs, and that's enabling. It's enabling people to live. And the idea is to provide them with resources and stop them from overdosing and dying, and hoping that maybe next day, maybe next month, maybe a year from now, they'll decide to enter treatment. Because I strongly believe we can't force treatment on people. It has to be voluntary. So those are the two things I would do: scale up treatment and then also scale up our services for people that aren't able to initiate treatment today. Maybe one more question? Yeah.
Didn't address, and I don't know if your organization is addressing this.
Mm-hmm.
I come from a middle class, relatively upper middle class sort of neighbor area in the suburbs, and we have had a rash of high school kids who have died of overdoses, either right after they graduated from high school or first year of college, but they had become addicted in high school. I am also a teacher, and we have had programs and things that really haven't worked in terms of getting these kids to never try these drugs in the first place. So I don't know if your organization is involved in that, but that is something I'm just curious about, what you guys, if you are doing anything in that realm with going to high schools and middle schools even.
Yeah. So when we were tasked by the governor with writing a strategic plan, the goal that was communicated to us was reduce mortality today. We have to stop people from dying. So the strategies that myself and Dr. Green and Dr. Rich recommended were immediate things we can do to reduce mortality. The next step is exactly that, is looking at primary prevention. How do we stop initiation of these drugs? So that will be coming, and we're just starting to embark on that process now. Unfortunately, we don't always know what works well. We know what doesn't work well. DARE programs and scare tactics tend not to work well. We learned that in the 90s. But I'm sad to say there aren't a lot of evidence-based primary prevention programs out there. There are a couple that have been evaluated that are effective, and I think they need to be looked at more. And more research does need to be done in this area, certainly. So we have a long ways to go on that front, I'm afraid. Great, thank you.